Hello, everybody. We are so glad with the whole Froggy Mouth team to virtually welcome you here in the Biotech Dental Ortho Studio for a wonderful lecture about the Froggy Mouth. As you know, or maybe it's the first time you hear about that if it's the first Froggy Mouth lecture you attend, we are very glad to see all of you attending every 2 months our webinars, because today is one of our every 2 month webinars that we are organizing for all of you guys. People following us, we know, from so many different countries. Today we are very glad because we are having more than 600 people that registered from 47 countries, and we are always so glad to see that month after month you keep your interest for discovering new ways of using the Froggy Mouth. That's the point, that's the topic of all those webinars we are organizing, to show you through one practitioner one way of using the Froggy Mouth device. Not saying this one, the previous one, or the following one is the one. No, just one way. So, month after month, you can better understand the different use that different practitioners are having about the Froggy Mouth device and create your own protocol regarding that. So, once again, thank you everybody for being there. And today, I have to say that I am especially happy because we are welcoming a doctor I wanted really to introduce you for such a long time. I was unfortunately not knowing her yet when we organized the Froggy Days 4 years ago now. That is still available in replay. That's why we were not having one beautiful lecture to show you and to put you available, because the person that is going to present you the lecture of today is really, I have to say, someone that I appreciate so much the support and the clinical evidences and hints that she is giving us month after month. Us as mother company, we love to get users like that, following the philosophy that we had when we created the Froggy Mouth device. As you know, Froggy Mouth was created 14 years ago now by Dr. Patrick Phillips, that was having one specificity. At the Robert Debré Hospital in Paris, he really promoted the transdisciplinary approach, making all the different specialists working together. Nowadays, it starts to become something, but it's thanks to the people like my father 30 years ago, but especially like today, Dr. Ilia Jipa, that we are able to promote this transdisciplinary approach. If you are there, it's because you registered, so you already know who is going to make the lecture. It's Dr. Ilia Jipa that I am so glad to welcome. She was arriving today directly from Bucharest, Romania. She is having a wonderful and beautiful integrative health center there. She's practicing orthodontics, but not only orthodontics, also having different PhD in the oral health and health of young patients. She's now practicing orthodontics for the last 15 years and especially having a focus on the transdisciplinary approach, making all the specialists cooperating and working together to build the best strategy, best clinical strategy for the patients. You can find online the different papers that she was writing on many subjects, including this one. She's the author of more than 40 papers, and she also created another institute of Oroposturologia Myofunctional Therapy to promote once again the common protocol we can have. What we are going to present today is, let's say, an inflection point. Ilia is going to show you the day when she started to really care about the function. We could really see discussing with her and attending all her lecture, the moments when she realized that all of that is going to change the way we are doing our jobs, and for having already seen the lecture before you are going to see it, I can already tell you that I was absolutely sure when I was seeing the PowerPoint for the first time that it was going to be one of the best lectures that we organized here for the Froggy Mouth webinars at the Biotech Dental Ortho Studio. So I am so glad, Dr. Ilia Jipa, to welcome you and leave you the floor. It's your time to show the audience what you already showed me. Thank you so much for coming.
Thank you, Guillaume. Bonsoir, bună seara. Hello, everybody. And I'm so happy that you're here with us tonight for the presentation that's literally my favorite.
Can you do that first?
Yes, I will speak to that. Okay. So thank you so much for joining us, because my presentation is actually kind of the story of my life, the story of how I became an orthodontist that would appreciate function rather than form. So I will present the steps. I will present also the mistakes. In this lifetime, I do have multiple roles. However, tonight I'm coming in front of you as a mother and as a colleague. I was born in Romania, in a very small town, a safe one, next to the border to Ukraine. My mom, she is a surgeon. She was a very active surgeon as a kid, so I practically grew up in the hospital. That's why precisely I chose dentistry to be my job. In my 9 years of practice, I realized that all the breathing, the chewing, the tongue ties, the oral habits that I will be presenting today were not really addressed. So that's why some dentists that are here might know the joke that us dentists are not really doctors. This is the joke that I've been told my whole life. And at the beginning, I was a bit frustrated about that. But now, realizing that all these issues were not really addressed during my 9-year studies, plus all the lectures that I attended after, it's not so bad that they make this joke. So as a beginner orthodontist, of course, I started working with kids. Many of them were 6+. It's when the parents would bring the kids in because the permanent teeth would look completely different than the milk ones. And that's why I started, of course, with corrective mobile appliances, some functional ones, and of course, the RPEs. Later on, when I discovered the braces, I fell in love because of the movement, because of the speed. After trying them all, I remained to the metal ones, the ceramic ones, the vestibular actually ones, and the clear aligners. In the meantime, I also remained in university, where I was in the prevention area and the orthodontics one, and I had my kids. My kids are amazing 2 kids, but completely different. And I experienced that since their birth. However, one of my mistakes is that I did not realize why their childhood was so different. My first one didn't latch. He had artificial feeding, finger, thumb sucking, reflux, a lot of issues with the food, soft food mostly. I don't know, if I remember well, there were 4 or maybe 5 types of food that he would eat. And of course, a lot of issues, childhood issues with a lot of antibiotics and anti-inflammatory. Even when I had my second one, I still didn't realize. I just thought that they are different kids. I was, of course, also validated by the doctors and also the other parents that these are normal things for the small kids, so I remained in the expectation zone. However, in 2018, something happened that completely changed my life. And where I am today is because of what happened back then. My older one, which was 6.5, 7, woke up with a swollen left eye. By the time we realized that this was not an ophthalmology problem, but rather an ENT problem, the eye went like that. What happened is that he was diagnosed with sinusitis. Sinusitis, but an ethmoidal one. What happened is that during the time that he had all those colds as a kid, the inflammation somehow stayed there, even though we vacuumed him a lot, even though we blew his nose a lot. He was even bigger. At that age, he could blow his literally nose, so that was no problem. We never thought of that. However, that infection, by the fact that it stayed so much in the sinuses, carved its way through the bones and went toward the eye. When asking the doctors, how could this happen? We were a family of doctors. We were surrounded by doctors. How could we not see that? We realized that his sinus, his nasal cavity was so narrow that the infection could not be drained with all the vacuum cleaning and with all the nose sprays that we would use throughout the time. And that was the moment when I actually realized that maybe I could have helped him with something, which is expanding the palate. However, he did not have a crossbite. He did not have any signs. So I kind of asked the ENT, we had that talk, and we realized that, yes, that could have been a viable situation and solution. Going back to the pictures and to the videos, the signs were all there, only that I did not have eyes at that moment to see it. He did snore, however, he snored through his nose, not his mouth. He did have a long face with some dark circles. He did sleep at night, but not enough, apparently. And for the dentist and orthodontist, we can spot the gingival smile and the lack of teeth, the lack of spaces between the milk teeth. So I felt extremely guilty. I felt extremely bad that I did not do something for my kid. And this is when someone told me about the orofacial myofunctional therapy, which I thought at the beginning it's a completely new field. How could I not hear about this? What is it? So no matter what definition this field has, at this point, I find it that it's a preventive medicine, integrative and functional for real. The leaders of myofunctional therapy is the AOMT, led by the amazing Samantha Weaver. I really recommend that you check their website, that you check their courses. But anyways, they have this amazing poster with all 32 myofunctional dysfunctions. Even when I read about it, when I heard about it, I didn't know that there are so many. It starts from oral breathing, goes to bruxism, clenching, speech disorders, hypotonia of the muscles. It goes to the lower tongue posture during rest, also the forward head posture. So realizing and reading about this, I actually realized that my kid was the typical oromyofunctional dysfunction patient. He had snoring, he had some oral breathing, no latching, artificial feeding, therefore. He had the narrow maxilla with the narrow nasal cavity that we've all seen what led to. And of course, the preferences for soft food. And also, we had some growth problems, but we will see later in the presentation. So my aha moment was exactly then. I realized that up until then, I would look at the shape, I would look at the form, but had absolutely no idea about the function. I did know something about the adenoidean phase, but I didn't put it in the context with my job. So I started reading. I started reading a lot because, again, I thought that this is a very new field and this is something that would explain to me why I did not hear about this. And surprise, the field is very talked about for the last 100 years plus. The first book that appeared on oral breathing and its modifications towards the facial structures, the posture structures, was in 1870. Then Edward Angle and the dentist and the orthodontist, of course, know Edward Angle, this is the Bible that we're going through, the key of Angle, also recognized the oral breathing as being the major and the most constant one in provoking malocclusions. Very interesting, the student of Edward Angle was actually the one that wrote the first book of myofunctional therapy with exercises that would help patients in their orthodontic journey. It was very interesting for me to find out about the magazine, the dental magazine of that time from the 1900s, and there were some specifically extraordinary articles there that are saying extremely hard things. For me, it was very bad to see this because indeed I did feel an ignorant mom. I did feel not knowing a lot of things that I could not help my baby, and I waited, and this is specifically what this article is saying, that a very ignorant man will have to wait to see how the malocclusion is installing and literally how it modifies the face and the body. Another article that says that ENT doctors and dentists should really make a team. Although I don't know about you, but I don't see any ENT doctors, a lot of them that are sending patients toward us. That's another thing that we will cover during the presentations. Anyways, the idea is that the signs of mouth breathing, the chin receded, and all the other facial features are clearly something that are spoken and talked for the last 100 years. However, I did not know about this and did not put it in the context of the teeth. Very interesting, in 1836, Charles Dickens speaks about Joe, the fat boy that looks lazy, has a sleepy expression and a loud breathing. He sat with mouth wide open and his eyes nearly closed. So this is the first description, actually, if you come to think about the modifications and how a oral breathing child looks like. Again, another paper that really caught eyes was Dr. William Hill that's called On Some Causes of Backwardness and Stupidity in Children. So he really recognizes that the children that oral breathe look lazy and lacking in intelligence. Another epic study that I really liked was the one presented by another dentist who went for 10 years and searched not the sick persons, but the healthy ones, and checked what are they doing in order to have dental health, facial health, posture health. This is something that Dr. Stephen Lean in Dental Diet took over and made a more newer and adapted book. And the last one, not the least, but the last one, is more new. It's 44 years ago. This is the study that really caught my eyes, and I have pictures with this in my practice because I really need to show the patients what happened. is the study of the primates, where they took a lot of monkeys and they divided them in two groups. One was nasally obstructed, the other one was left to develop naturally, and they looked at how their faces would change during 2 years of time. So it was clear. There was definitely a cascade effect when we have a myofunctional dysfunction, such as oral breathing. The newer articles that are speaking about this oral breathing and the other myofunctional dysfunctions, however, entered with something new, something that I didn't know back then. And they're talking about sleep-disordered breathing. Sleep-disordered breathing that can start from primary snoring and can go to the pediatric obstructive sleep apnea. We're talking about pediatric, but this is applying also to adults as well. They say that at this point of our lives, there are only 5% of kids that are having obstructive sleep apnea. However, I'm not sure about this. Maybe you can help us with some new data. If you find them, please write in the comments. It would really help. But even if there's a larger percent, I'm sure that this percent is usually taken by the masks, by the fact that they are receiving a CPAP. We are not going to talk about what CPAP actually does to the facial bones, but it's clearly that this is a golden standard, and it's clearly that without it, the kids or the adults cannot survive the night. The second thing that can help in obstructive sleep apnea, however, it is not very well talked about, and I'm not sure there's a lot of sleep physicians that are sending patients to wear this type of splint. It's called a mass or a MAD. I'm sure a lot of you know about this. It's actually moving the mandible forward and taking the tongue out of the airways so they can get through the night. However, I found out, but I might be wrong, again, if you have any data, please write to us in the comments, that because of the CPAP is not really taken into account by a lot of patients that are wearing them. I've heard that they are around 60% that are actually wearing it. MAD could be a thing that maybe the sleep doctors, pneumologist, or it doesn't matter the name, will send the patient to search for this type of appliance. It's very interesting that even though we do not have a real percent of those children, and even if we do have the percent of children that are receiving CPAP, what happens to the ones that are not, are in between the no apneas and the apnea that that makes them receive a CPAP? What happens to the ones that are having 10 episodes a night, an hour of suffocation? We have clear reports now that the reduced regional gray matter is a fact, and that the IQ can drop up until to 10 points. So I found these, the FDI recommendations and the AAPD recommendation that airway should be taken into consideration in screening, and of course this goes directly to the dentist. I do not know, I did not receive any type of form that would make me do that in my own practice, but again, please do write if you know of any actions of this type, or it's just an announcement made. So, having all these data in my mind now, and again, for me it was completely new subject, I tried to make it simple and somehow tried to reduce all that I knew into 3 little boxes. Breathing during the day and during night, the tongue during rest and during swallowing, and the chewing plus the nutrition. Of course, the main objective when entering this myofunctional field is going to the root of the problems. And of course, knowing again all of this, I realized that from now on, I will start looking at the function in accordance to the form, because clearly It was the first time that I heard that form dictates function and function dictates form. I knew about this thing from the architecture, but I did not know that it applies to my field as well. So at the beginning, I said, let's start with the consultations. I will bring the patients in and I will talk to the parents, tell them about this thing. And I want to tell you that I literally caught myself taking the air out of my lung, explaining to them. At the end of the consultation, they would look like me and say, yes, but you know, we are here just for you to straighten our teeth, because 80% of what I did in the consultation started to go a lot on the breathing, the chewing, the tongue posture, and everything. So I realized that those persons had absolutely no idea what I was talking. Maybe I was giving them too many information. So I decided, as a first step, to make a letter to them. Send them a letter a few weeks before the appointment so they could read, they could understand what's going to happen in the consultation. And of course, ask them to follow the kids, look at their breathing. When are they breathing through the mouth? How much time are they breathing through the mouth? How are they sleeping? Ask them videos. Ask them to put some notes on their notebook before coming to me. And it made my life easier, and it made for them more clearer what's going to happen in the first consultation. In order to adapt my speech to their knowledge, I had to read some books. So I really recommend these books. They're amazing in terms of really clearly explaining and making somehow a plan, because I caught myself having too much information and I would not have the structure of how to say it to the patient without overwhelming them. The other part of the books, which are connected to the tongue, and of course, the scientific froggy mouth file, it's fantastic. I really recommend that you ask it from the froggy team. In terms of evaluation, what I did is take my form of evaluation and transform it into a functional one. So this is from a 1 page or 2 page that I had before I got to 6 pages. Maybe it's a bit too much, but I really want to cover everything when I'm seeing the patient. But more or less, what I did is took the fairest 6 plus 4, and adapted it to my type of evaluation. This is a free form. You can find it. It's made by Dr. Zaghi. I think he did it in collaboration with the late Dr. Cristian Guillemino, which is the father of the sleep medicine. So I really recommend that you, if you are interested in including the function in your practice, definitely this is a thing to take into consideration. Besides the X-rays that I would ask before the consultation, I included this one with the airways. It's much more easier for me to explain the patient to the parents of the patient, and it's much more correct to see the movements that we're making and what it does to the airway. So I find it a very amazing tool that we have now. In terms of photos, I did skip the intraoral and the face photos that I would do before, and I would make the kids, I would photograph the kids full body, because definitely those kids have also postural problems. You can see it in the picture, but it's very easy. It's very easy to spot when you put a patient to stay like that, relaxed. You don't show him how to stay, you just put him, you make him breathe, maybe do some movements, and you realize that his posture is a bit changed. So if you work with any kinetotherapist, it's very easy to send them directly the photos if you have a common patient. Same, lateral, of course, the intraoral photos that we all have. And I added to the intraoral photos the opening of the mouth and the lifting of the tongue to see the range of motion of the tongue and of the mouth. In terms of breathing, we said that I divided it into 3 small boxes. I have a lot of pictures in the practice. I do tend to talk a lot. I do tend to explain a lot. I do tend to overwhelm them with all that information. Therefore, I do need some help in the photos, and I simply explain them. The breathing cannot be seen. The breathing cannot be taught, cannot be heard. And of course, show them all these photos that literally shows the changes that this can do to their faces. I also explain to them that if they have any type of obstruction, I cannot help them because my treatment goes on closing their mouth. So I cannot put a child into any type of discomfort. So that's why the first specialist that they will see is definitely an ENT doctor, because I explained to them the human skull is like a house with a ground floor and a first floor. So no matter what I do in the ground floor, it cannot be finished until we check the first floor as well. For the ENT doctors, I did have a challenge because I don't know how many of you had this situation, but there are some that did not hear what we're doing when we are focusing on these functional problems. So even though I sent some patients, I was somehow sabotaged because they would send the patients back, or they would say, just like in my case, because I didn't say in the beginning, no, I did have some adenoids. However, they were not too big, not too small, but not to be operated. So that's why we waited so much, and this, what happened because of this waiting time. I also explained to the parents the sleep disorder breathing pattern, which goes from loud breathing, primary snoring, that can go to upper airway resistance syndrome and lead to sleep apnea. And if they suspect any type of apnea, they would definitely need to check a sleep medicine doctor. For the kids, my sleep medicine doctors that I'm sending are sending the kids to polygraphy, and the others are going to the polysomnography depending on the age, and of course depending on the doctor and the age of the kids. However, I had to find my persons to where I would send the patient, including the ENT, including those doctors, the sleep medicine doctors, because of what I said before. It's very rare that an orthodontist or a dentist or a myofunctional therapy or a therapist or a kinetotherapist would send patient to this type of doctors and be taken into consideration because they don't see the connection, and neither did I before. So I asked them to video. I asked them to video their kids 1 hour after they fall asleep to realize how the loud snoring looks like, to show them that most of the kids do have an open mouth posture, very weird positions sometimes. It's easier for me to make the collaboration with the parent. Sometimes we find apneas. I will leave this video to, I don't know if you know this video, but this was shocking for me the first time that I saw it, so I am presenting it to everyone. So at the end of all this protocol that I really implemented in my practice, for me to have a discussion with the parents, for me to send the patient correctly and not being sabotaged by the other doctors, I literally explained to them that it's not easy and it's very hard when you want to switch from the food hole, the big hole, to the two small air holes. I couldn't say it better than Rhonda did this wrote in this book. It's a fantastic book. This is the last book that I wrote, that I read, and I really like it. I really recommend it to you. And the fact that the final act of when we want to restart or retrain breathing is that the body needs to get accustomed to the enough air through the nose feeling, which is hard for some. In terms of chewing and nutrition, I talk a lot about the Corrucini studies, the anthropologist Corrucini, which had 3 different generations with the increase of the malocclusions from generation to generation after the including of the soft food. And of course the modification of our skull. And I talk to them about the Wolff's Law. I don't tell them Wolff's Law, but I'm just saying bones need to be stressed in order to grow. You need to help us with chewing. Even if they don't want hard food or very fibrous one, you can find things that kids can chew, so it helps the growth of the bone. The same with the muscle of mastication. And of course, if some of them ask me, okay, so what types of food should I give to him? So I am teaching them to find a nutritionist or a dietitian that could help them find a diet that with not so soft food, and try to include little by little the more chewy foods. However, this is a thing that I really want to speak about. There are some children that are having sensitivities, so this is another subject. But for the mastication and for the growing of the bones, we really do need to push the parents to help us with this matter. In terms of tongue and swallowing, I did leave it last because it's more to talk about. At the beginning, after reading and putting all on paper, I realized that when addressing the tongue, definitely I will have to address the tongue ties, the tongue tone, the tongue space, and of course, how do we do with the habit correction of putting the tongue down during rest. And this is a very funny story because at that point of my life, I really thought I finally figured everything out. So this is when I receive a phone call from Froggy Mouth, from Daria and from Guillaume, that want to tell me about Froggy Mouth. I already knew about Froggy Mouth from a wonderful orthodontist in Italy, Simonetta Meuli. So I was really happy that they called because I knew that I want to buy the device. However, they had this presentation of 1 hour where they would talk to me about neuroplasticity, and I was trying to tell them I want to buy it. It's no need to. But then I realized that actually I did not have it all figured out, because when it comes to the tongue, it's not enough to see it. It's not enough to send the patient and say, we need to resolve this. The secret to the tongue is that you need to keep it in the long run. So this is just a small connection with Froggy Mouth. We will speak about later about what it does. So in terms of tongue ties, definitely tongue tie in English, it's tied. However, in Europe, generally we use the word frenum or frenulum, which comes from the Spanish word frenar, which means to apply the brake. When we have a frenulum or a tongue tie, definitely all the 4 intrinsic and extrinsic muscles are going to be really, really affected if this tie is shorter than it should be. At the beginning, I used to look only at the tongue, if it has any tie. However, now I'm taking a really big interest in the other ties of the mouth, which is the upper lip, sometimes the lower lip, and also the lateral frenulums. Because I was so passionate and saw that the history had 100 plus years ago materials that I did not hear about or heard about, I searched for the tongue tie history. And the first time that is being mentioned, it's in the Bible. Apparently, Moses was a tongue tie, slow of speech and of tongue. However, France definitely ruled the things, because in the 1600s, there were a lot of papers and a lot of doctors that would recognize tongue tie, diagnosing it and cutting it. However, the decreasing happened in the 20th century. Why do you think that happened? Because of the rise to the formula feeding. So even the kids had tongue tied, it was very easy for them to feed and nurture. In the 21st century, there's a new renowned attention with all these articles that are seeing, and with all this interdisciplinary power, with the consultant, like lactation consultants that are appeared, then definitely it caught eyes again. So whether we have a anterior or a posterior tongue tie, the tongue doesn't always have to be like that, like I thought in the beginning. I thought that having a heart-shaped tongue would be the thing that would show me. However, we do have tongue ties that don't look like that. Excuse me, I would need a bit of water. What I'm doing in my practice now is doing the measurements with Kotlow and the Coryllos. For the Kotlow, actually, I put this picture because I want to show you the first mistake that I did by measuring the tongue tie. No, for the Kotlow, we actually are interested in the free tongue length. In terms of Coryllos, definitely we want to see where the tongue tie is, where the tongue tie's point of insertion is. However, in my practice, I'm usually using a lot the TRMR tip and TRMR lingual palatal suction, which means at the biggest opening of the mouth with the biggest lifting of the tongue, we would see how much the tongue goes up. And of course, the lingual palatal suction, we ask the patient, if possible, to put his tongue up on the roof of the palate and see how much it can stay there. In terms of this measurement, it's very interesting, and when I found out, it made sense. We really need to see a wide opening of the mouth in order to do that classification, because some do not have an open mouth to the maximum and they can lift the tongue up. So we are interested in how much the patient can open the mouth and how much the tongue goes to the incisal papilla. I'm not going to speak about the tongue ties because there were a lot of other presentations way better. However, I want to acknowledge the fascia. The fascia, which is a sheet of connective tissue, primarily collagen, it's kind of like a spider web, I would say. It's all over our body. And why would an orthodontist be interested in the fascia? I also found out when I entered this new world, it's because of the deep front line. You can find about it in the Anatomy Trains by Thomas Myers. And why would I be interested in that? It's because of the hyoid bone. Each time we have a restriction in the deep front line, the hyoid bone is moved backwards. Therefore, it lowers the larynx and it narrows the airways. For at home, I'm sending these pictures for the parents when we are asked by parents of newborns how can they see if they have a tongue tie, and it's very easy. during sleep, you just open a bit the mouth and see if the tongue is rested on the roof of the palace. Some parents are not very happy when we tell them that they have ties, and they're not very happy to cut the lingual frenulum, and they ask me what could happen if they do not do that. I don't know if this happens to you, but I usually tell them it's fine, it's not the end of the world. Of course, the kid will survive also with a tongue tie. However, it will adapt every movement, every food that they eat, every food preferences, and also their breathing according to that tie. So I give them the example with a child that doesn't see very well, and usually will bring the phone or the screen very close so they can see, or the shoelace example. In terms of tongue tone, however, it's very interesting because we see kids with a very nice range of mouth opening and a very nice lifting of the tongue. However, in the rest posture, they are looking like that. This is where I speak about Davids's law, which is kind of the same like the Wolff's law of the bones, which states that the soft tissues like muscles, ligaments, and tendons remodel and adapt in response to the mechanical stress placed upon them. Before, I used to use a lot of stinging things. I'm sure some of you know these. However, no matter the shape, no matter the size, I did realize that at some point the tongue is so stubborn that no matter what you put there in the mouth, so it's being stung, it will still be there after some time because it will get used to that. This is a kid that came to me after 2 years of rapid palatal expander with a fence. However, when I saw him and realized that, okay, we need to do something about the tongue, the bite was corrected, what are we going to do with the fence? Because he would still stick his tongue under the fence. So it was so well integrated, this reflex of lowered tongue posture, that even with the fence, things will not work. So I told the parents, let's take the fence out. We have a white palate. We need to put the tongue up. Now we are in treatment, but it's an extremely difficult case of lower tongue posture. Actually, I find this case is a bit more difficult where they have the ability to lift their tongue, yet the rest position is down. In terms of tongue space, how do I see it? I see it first when they are lifting their tongue up, and then we see if the tongue overflows over the teeth. Definitely we do want a Roman cathedral type of roof and not a Gothic one. However, no matter the type of expanders that we're using, it's no point if we don't put the tongue up. This is a thing that I realized. This is a thing that I'm focused on in the last years of my practice. And this is a thing that will not put the kid on my chair if the parents are not willing to do that for them. The atypical swallowing, we can take it in the practice just by putting the 2 fingers inside the kid's lateral sides and see if they, when they swallow, if they push my fingers, or give them the cheek retractors and film them while they're making this swallowing It doesn't have to be necessarily in front. I found out that there are a lot of kids that would put their tongue lateral. This is a case that I wanted to show it to you because it was quite difficult to make him understand where to put the tongue, even though he had froggy. He was kind of big, but he needed to do the exercises and he didn't want to do it. So at some point, I started to negotiate with him. I said, okay, we're going to stuck with the braces for the rest of your life if you don't do something about the tongue. And as soon as I told him that, he started working on the tongue. And now I just took out the braces. However, I did not have time to put the final pictures in it. So because this tongue is such a stubborn muscle, we really need to work on it. So the times that I understood now is that the 21 to 66 days while the therapist is working, I'm not doing myofunctional therapy. However, I do have people that work. It's sometimes not enough. It depends how much the tongue stood there. It depends how rooted is this habit, as I showed you with the previous patient. So it does take a conscious effort. However, the forming of the habit, I tell the patient around 2 to 3 months they're learning the new habit. Around 2 to 3 months they are integrating the habit, and around 6 months then we have to stay and understand that the patient really understood this position and it's keeping them and there's no relapse. So this is why I really fell in love with Froggy Mouth, because they would explain to me what happens with the long-term memory. This is why I was surprised at the beginning when they were talking to me about neuroplasticity. However, now I try to explain to the patient and also to my other colleagues that this is, in the long term, this is the secret that makes the difference, because everybody can make exercises. However, not everybody will keep this and relapses might appear. So in the Froggy presentations, I'm not going to hold the Froggy presentations because all over the world there are persons that are having these presentations and the support is fantastic. They have it on the website. However, just a short story is that for the long-term memory, either you need repeated stimulus, that's exercises, or maybe remembering, put the tongue up, like continuously, either a little emotional shock, and this is why maybe I will make you curious, the ones that are not Froggy users, I really would like you to hear this story about the small emotional shock. When the patient puts the Froggy in between the lips, they're not finding their typical swallowing, usually the primary typical swallowing. So that gives them a little bit of panic attack. So I do use Froggy. I do use Froggy from small ages. I do use even before 3 years for some patients. I do it for the adults as well. I do it also for the adults, not just in terms of myofunctional or orthodontics, but also in the TMJ patients and the sleep apnea patient. And what I find fantastic is that we do have disability kids that we treat. So it's a tool that really does work with them because it's easy to wear and it's not long. And they're not putting something in the mouth. I'm talking now about the ones with sensibilities. So, as a conclusion, who is our patients? Who are our patients? Definitely we have patients with smaller faces. We have patients with smaller airways. We have sick kids. We have long tongue kids, low tone tongue kids, low muscular tongue kids. We have a lot of kids with oral habits such as thumb sucker or prolonged pacifier. We have adenoidean faces. We have different muscle patterns, all kinds of shapes of arches and bites, no spaces between the milk teeth, bad postures, and with a preference for soft food. And who are we? Because we are a lot. I don't know if you're familiar with the fable of 6 blind scientists that are touching an elephant, and depending on where they're touching, they say that it's a spear, it's a fan, it's a wall, it's a rope. However, don't you think that we are kind of the same? Because we are touching the same elephant. We are touching the same. In our story, the elephant is definitely our patient. However, I did not know that next to me there are other therapists or other colleagues that might help me in this field. So I suggest, and this is one of the topics that I really like, the interdisciplinary power, because this is like an advice, or maybe like let's do it, because if we take our blindfolds out, we will see that we just want to do the same thing, treat that kid, treat that elephant. However, if we touch it in different size and we don't know about each other, we might do things, but not in the long term, and too many. One specialist cannot do it all. So clearly, the interdisciplinary collaboration is essential in my point of view. I have a lot of specialties that I collaborate with now, and as an advice, search them, go directly to them and talk about it. We cannot just find out about the specialty and send the patient, because they might not know who we are. They might not know what we do. We might not know what we do. So when you go and speak to the specialist, he will be very open or he will not be open, but at least you know your future team. My team now is bigger. However, in terms of entrepreneurship, I definitely wanted them close to me. So I have a kinetotherapist, I have an osteopath, I have a myofunctional therapist, I have a surgeon that cuts the ties, I have a pedodontist that cuts the ties, myofunctional therapist, pedodontist, and a manual therapy. These persons are together with me in the practice, and where I enter is actually here. I'm here at the initial consultation. I'm here when I'm giving them any kind of myofunctional devices, and I'm here at the orthodontic treatment. However, the myofunctional devices is also given by them, not just by me, because now we have a lot of physiokinetotherapists that open their eyes to this type of evaluation or this type of approach, and they are also offering this in their treatments. I'm speaking about osteopaths. So, as protocols for the newborns, definitely they're coming for the tongue ties. Usually they're being diagnosed by the lactant consultant, or they heard about us and they know that they're having breastfeed difficulties. The team that I'm working with in terms of newborns is definitely an osteopath who understands the facial system. This is super important. And of course, the surgeon or the pedodontist that releases the frenulum, again, osteopathy. And I'm also teaching through a myofunctional therapist or a manual therapist or even the kinetotherapist the type of massages that we need to do after the frenectomy. For the patients 1 to 3 years old, if we have a tongue tie, it's the same protocol. Pre and post frenectomy exercises are standard, or if they cannot do the exercises, which is very rare to do in this type of ages, definitely we will need to put our hands inside their mouth, and the parents need to be part of the team. He needs to understand and not just stick with the therapist itself. So what I'm doing is I'm eliminating all the bottles, all the pacifiers, all the things. I'm addressing these oral habits, such as biting of the lips or finger sucking. I'm giving them things to chew, a lot of chewing. And of course, I'm teaching also the parents how to massage, how to enter in their kid's mouth, because what we want is to lift the tongue up to help proper breathing, nasal breathing, and also the expansion, the natural expansion of the palate. In the patients from 3 to 6 years old, we already start to get in with myofunctional devices. Also chewing one, froggy mouth. If they are compliant, we can start with easy exercises, but I'm always counting of going inside the mouth and using the massage. And of course, for this age, this group of age, We can also do the orthodontics. I don't know why they call it the RPE, rapid palatal expansion, because in this case I'm not doing anything that's rapid. Everything is very slow and it's very controlled. However, even if we do use this at the end of the treatment, which is definitely smaller in terms of months or months, I'm always taking into consideration that after we are expanding, we need to lift the tongue up. So each one of these patients did receive a froggy after. In patients 6 to 12, definitely it's the same, only that the orthodontist clearly goes on much more mechanical forces, and I do use the myofunctional during the treatment. There are some, I will show you some cases where I'm not starting the treatment until they are rehabilitating a bit the muscles. 12 plus years and older, definitely the same. Orthodontics, but always with myofunctional taken into consideration. For adults and seniors that are not very excited to get braces or orthodontics, except the situation where they are sent by other colleagues such as implantologists or prosteticians, definitely I'm more interested in how their jaws are, in how their temporomandibular position is, and of course if they have any snoring or sleep apnea. So that's why for most of them, if they don't want ortho and are into our practice for TMJ or for sleep apnea, I will use the same protocol as well. Work with the muscles, lift the tongue up, do as much as you can, because this is part of the TMJ but also apnea protocols. In terms of cases, we are dentists after all. Even though I switched to being a orthodontist that's more interested in function and has more respect from the function rather than the form, I still photograph teeth, because this is our, I don't know how to say, the thing that we are presenting ourselves out there. However, tonight I don't want you to look necessarily at the teeth. I want you to look at the faces, because the faces is the difference of my job, the way I see it now. We see definitely better smiles, and I see the patients are being very happy, because this is why they're arriving or searching for an orthodontist. However, the success that I'm seeing now is in the muscular balance of the kids, the smiles, the postures, and the fact that the parents are telling me that they finally have a good night's sleep after all this time. So I'm using froggy. This is a case, the first cases are exclusively treated with froggy mouth. This is class 2s, I'm using froggy. Also class 2s, I'm using froggy. I don't have a before picture because she really didn't want to be in the practice. She cried so much. However, after she got friends with froggy, which was not something inside her mouth, she wanted to become the ambassador and say how wonderful it is to get a myofunctional device. Classes 3, also, I'm treating exclusively with froggy, with some build-ups in the back, of course, but with froggy. This is few months treatment. Open bites, 3 months treatment. Please don't look at the bite. Please look at the face and the profile. This is the 3 months where I did nothing, like literally nothing. I just gave her a froggy mouth and gave her some small exercises. It's amazing because everybody or the mom said, wow, fantastic job, you did extraordinary, and I actually did not do nothing. This is pure myofunctional treatment. Same. I really wanted to show you this case because I found it super interesting. An open bite. I saw the girl, I think I saw her 2 months ago. This is not an open bite created by the tongue. The tongue is perfectly lifted in the roof of the palate. However, if you check the lips, this is what created that bite. I know it doesn't come in the context of my presentation today, but I found it very nice. I don't know if you had cases like that. Please tell me if you found cases like this in your practice. Froggy, I'm using for the tongue, but also for the lips. It's very important to have closed lips at the end of the treatment. This is the best result as far as facial arrangement. So yes, I'm using Froggy also for the lips. This is a case, a very interesting case, a beautiful baby boy who is extremely well developed. However, he has a tongue tie. What do you think the treatment will be? Because definitely I will not put this kid into ortho. We will make the pre-frenectomy, frenectomy, and post-frenectomy exercises, and of course, he will get only a froggy mouth. Even though he's small, and because he had a crossbite, I definitely had to expand him. But after we expanded him in a matter of 5 months, I think, we put him on myofunctional treatment. Also here, expander plus froggy mouth. The occlusion is not closed. However, the success is that before the tongue was right in between the teeth. However, now it is lifted. Class 3. We use the masks, and of course we use all kind of devices for expanding. It doesn't matter. This is another 3 months case. We are finishing soon. However, I make sure that his tongue goes up to the new place that we created. It's very important. This is a very interesting case because this case, usually I'm not staying with kids a lot in treatment. I'm doing phase 1 treatment or phase 2 and phase 2 treatment. However, this kid, for 1 year, he has aligners. He had that gap in between, and something was wrong. I did not put him on myofunctional because parents decided aligners, mandibular advancement, ortho. However, seeing that the things were not going according to my plan, I asked them questions. What is he doing with his lip? What is he doing with his mouth? No, everything's perfect. The kids wear the aligners. However, I made them film. And during the night, he used to suck his tongue in between the aligners. So I said, we make a stop. Now we go on educate the tongue, and then we continue with the aligners. We keep that aligners what your number, let's say 18, and then we will start again after you work a bit on the tongue. And things went completely different, like 3 months after we could see the results that we expected for 1 year. Same kid. Another case, I wasn't very happy with the result. I couldn't bring his mandible forward in that. However, I'm very happy with the face because this is the face after finishing this mandibular advancement. This is the face constructed by the work on the muscles, the work on the tongue, and the work on the exercises for breathing and for the lips. And okay, of course, he got a froggy as well. All the types of patients that we're having, no matter the age, no matter the appliance that we're using, is working fast because they have very moldable bones. We can work with them. However, I did not do that before because I do not want to concentrate exclusively on these forces. Of course they will work. Of course we will have results. But what happens with the kids that we finish the phase 1 treatment? How are we going to keep them up until next phase? Maybe there won't be a next phase. Maybe we can save them from the next phase. However, muscles need to be taken into consideration from the start. And if not from the start, at least we will do it in between the treatment. Another case, Liners and Froggy. This is the open mouth, lateral open bite case that I told him I'm not going to take the braces off unless he does something with the tongue. He's a compensated case because he was pushing it for so long, and of course the parents would not want to hear about anything else rather than the braces. I told them that we're going to try to do as much as possible. Of course, we will close the bite once the tongue is taken out. However, the protrusion of the mandible was a bit too much. Another case that did not work on his tongue, and we still do not have the closing of the bite. This is the case that you saw before with the atypical swallowing. It is better now. You always see in the atypical swallowing the movement of the body, the movement of the head, the noises, and the struggle that they're doing when they're swallowing their saliva. It looks good. I'm not happy with this result, and it's not done yet. We're still working on the tongue, and we're still working on the, not necessarily the swallowing, but the tongue posture, the low tongue posture. The same case. This is a case that worked fantastic. I didn't put him braces until he resolved the tongue. He was so wanting to get braces that he worked on the tongue, and the treatment went fantastically fast, like 1 year. What was the best thing that I could do is that even if, let's say, he did not have place for the tongue, now he does. But if I would have started first with the braces, I would not have been sure that even if he has a palate like that, he would put his tongue up. Normally, for some patients, it goes naturally. But it's just like in the case of the ones that are being operated by adenoids. I don't know if you had cases like that. Please tell me. However, even if they have the operation, they still continue to breathe through their mouth, even though everything is clear. It happens the same with us. Even though we make their palaces wide and enough place for the room to fit in, they will not necessarily put naturally their tongue up. This is a case that I really want to tell you because, as I mentioned earlier, in terms of sabotaging with the ENT doctors, she barely could breathe. I could hear her breathing from here to the other room. She had changed face. She's smiling in the first picture, but she was a true adenoidian face. So I told the parents, you need to go to the ENT doctor because I want to close this kid's mouth. They would send me photos of how she sleeps at night, and of course she was in a very S position with the tongue open. So definitely I sent her to the ENT to see how big is the obstruction and how we can deal with that. And the ENT said, yeah, the obstruction is 60% plus, but let's wait. Let's see what happens. Puff, puff in the nose. Take this medicine, and we will see. And I'm okay. Let's try to see another doctor because the obstruction of 60%, I don't think it's that small. I think it's bigger. It was literally a kid that could not close her mouth. To the 3-minute breathing exercise that we're doing in the practice, where I'm putting them to swallow a bit of water or put them a wooden spatula in between the mouth. She could not stay for 3 minutes to hold, to let the air enter through her nose and be comfortable about it. So yeah, we did put an expander, and yes, the parents said that the sleep got a bit better, But on the long-term consequences, now she's on aligners. The parents are super excited and they're very happy with the teeth. I'm not very happy because I could not make this kid better, and I was not on the same side with the ENT that saw her. This is a special case for me. She used to suck three thumbs. However, what kept my occlusion after she definitely wore braces and cut the finger of the tongue, the finger sucking, it was the tongue that would stick there and keep the occlusion open. Of course, oromyofunctional therapy, just a few exercises and froggy mouth, and the result, the occlusion closed very quickly, unlike before. We did have some problems with the hygiene with this patient. However, the results are fine. In terms of patients like this, that definitely they need to go on ortho first. Even if we expand, she cannot keep her tongue up because she never had a palace, a roof, or a room for that tongue to fit in. So I'm starting with patients like that, myofunctional, plus froggy, in between the beginning of the treatment and the end of the treatment. After we do have a little bit of room, we need to make them aware that there's a roof out there that the tongue needs to fill. Same, lack of roof. This is a patient that I did not want to start because she would keep her tongue here for the whole day, and she really wanted orthodontics, and I said, no, let's do first the tongue position up. Let's see how things are going, and then I will put you braces. She was extremely compliant with the froggy and with the exercises. Of course, we went with braces. The parents did not accept that this is a surgical case. So I said, okay, everything that we will do will be definitely compensatory. She's happy, but I'm happy that her tongue is up. Same, a lot of patients that used to have atypical swallowing, oral breathing, just for the, and of course, the lack of room of the palate, and of course, the crowded teeth, crooked teeth. This is a case that, again, I did not put. I told her she's a surgery case, definitely. The parents said, no, let's try. We are willing to try everything. And I said, let's try. I didn't think that it will work. So for more than 8 months, I put her into myofunctional treatment. I gave her some chewing stuff. I gave her a trainer. I gave her a froggy mouth. I gave her everything that I could find in the practice to make her willing to try to switch in between them. So after almost 1 year, she came to me like that, which was fantastic. I could not believe my eyes. Of course, we went into braces. We got here. It's a case that I will always remember because this was me not believing in the treatment, but her believing that we can do something about her. So she proved me wrong. That's why now when I see patients that are not wearing, I'm literally super upset because I know how other kids are working, how other kids are responding, how other kids work with us as a team, and the results have to be fantastically rapid, unlike the others where you're asking them to do all kinds of efforts. Also the parents need to be part of the team. So this is what I'm usually telling them from the start. If you're not involved, things will not work correctly in terms of muscles. Another patient that I did not want to put in unless she educated her tongue. The teenage girls are very responsive because they really want their appliances in the mouth, either brackets or aligners. So they are doing things more rapidly. However, this patient, at the end of the treatment, which is here, she was not happy with her teeth. She was not happy with her appearance, and she decided to put veneers. Other patients that I did not have the agreement to post their faces, froggy exclusively with buildups in the back. RPE and mask together with froggy. Functional plus froggy. This is a patient that I remember, indeed, because he was looking good and he started pushing me, when will I take the braces off? However, at the beginning, I'm sorry, back then I did not take such good pictures. In the practice, some of them are very good, some of them are really not good. However, this kid had a very low tongue posture and continuously, and he also had some speech disorders. So I asked them continuously, okay, I'm putting braces, however, you need to do something about the tongue. So at some point, the teeth would look fine, but the tongue was still there. So I told him, look, if you do not come with the tongue like that, I swear I'm not going to take your braces off. And this lasted for the, I don't know, maybe 5 or 6 months. And when he came to me like that, he finally did the place, because he wouldn't want to go to the speech therapist because he said that he would not be a baby. So this is a thing that maybe we should be taken into consideration with the teenagers, because of how we put the problems when we put them that they need to go to the speech therapist or they need to do some exercises that for them are really looking like a joke or like a game. And maybe we should align our talk to the teenage talk. No matter how big and wide the palate is, we need to educate the tongue to be there. This is the final treatment for me, not just expanding the palate. For those who are asking or thought what happened to my baby boy after that horrible experience happened, he grew up to be a teenage boy. For the parents of teenagers, we are not at our best times of our lives. You all understand that, the ones who have teenagers at home. He's looking good. Even though he had a receded chin, he's better arranged. He's, of course, a nose breather. However, what remained after all that times where I ignored his functions is the body posture. So what we're doing now is to do kinetotherapy. We're still doing the tongue exercises because I didn't mention, but he was also a tongue tie, posterior tongue tie that was released after I discovered this new field. We're still working on the body posture, but also his head tilting. So this is the osteopath that helps me, and the kinetotherapist. Of course, the modern lifestyle does not help us at all because of all this screen times and the sitting at the chairs in exactly this position. I'm always pushing him, stay straight, but it's just like saying, lift the tongue up. Although maybe if I would say it, it would go into the long-term memory, but unfortunately he cannot because he does have that posture problem. My take-home message, because this is a presentation about the tongue, is take the tongue into consideration because it's a very good tool in terms of breathing. It's the most natural expander up until 3 years of age, even more. I'm always telling parents that the gap, the 0-6 years old is 80% of the facial growth with, let's call it the gold age, because this is where we can work on them a lot without a lot of interventions. And I also wanted to ask you this because I'm seeing TMJ here. For the ones that are orthodontists or dentists, have you experienced the increase of the TMJ problems in kids? Because lately I really noticed that this is a problem. I don't know if it's from the bites or if it's from the posture of this lifestyle that we're having now. However, there are some studies, but I'm really curious if you are, if you find this in your practice. So even if you didn't start it, maybe my story will be somehow inspiration for some of you that didn't start. Maybe my story is just another validation that for those of you who already started. Or maybe you don't believe in this type of approach. But waiting for the right time is not correctly. I am a true example of what happened. So that's why I'm very vocal about this. No matter how you treat them, no matter what you tell them or inspire them to do, in terms of chewing, in terms of exercises, any treatment is better than no treatment. And at the end of my presentations, I want you to remain with the changed faces. No longer the teeth, just the faces. Because these are the faces of kids that I was really treating differently than before. And again, my success now is not just the teeth, it's the way that they're sleeping. It's the dynamics in the family that has changed once these problems lessened a bit, maybe not completely resolved. So yes, I am here. I accepted the invitation for Froggy because I believe a lot in this product. I'm using it, as you've seen, before orthodontic treatment, during orthodontic treatment, after orthodontic treatment, and of course I use it complementary with other myofunctional devices, but also all kinds of orthodontics that I'm doing. I want to thank you very much for hearing this presentation. Please answer or ask or give me any types of feedback. If you want to work together, even though we're from different countries, we can take this message out, because I, again, used to be a mom that didn't know this, and I wish I knew this before. So this is why I'm bringing awareness on the subject. So reach out and let's make studies. Let's make this field known to other people. Thank you.
Thank you so much, Dr. Jipa, for, first of all, this wonderful lecture, but also for coming here in Paris, in the Froggy Mouth studio, that is also the Biotech Dental Ortho studio. We are so glad you could come from Bucharest to be able to share with all of us your deep knowledge about Froggy Mouth. It's always super interesting to listen at you speaking about this device that you are now super experienced about. But now it's the time for the question and answer session, because I was seeing during the live so many people asking you questions regarding your presentations. It's the moment for all of you that are watching us in live to type right now in the chat your questions, and I will directly ask all of them to Dr. Jipa. So see you in 1 second for the question and answer session. Thank you so much, Dr. Ilia, for this wonderful lecture. I can already tell you, because I was looking at the chat during the whole lecture, that all our audience all of you guys, once again, thank you for attending the lecture. Really enjoyed it. And there's already a lot of questions. I'm going to start with the first ones that we asked during the beginning of the lecture, but I still ask all of them just to make sure not to forget anything. But sometimes you insert in the meantime a little bit the question. One of the first questions is, how do you use the froggy mouth with the TMD and OSAE? Adult patients, is that in conjunction with myofunctional therapy and or palatal expansion?
So this is two questions.
It's
Separately,
one question in two.
Okay, yeah. So definitely for the TMJ patients and the sleep apnea patients, we need to put them on exercises. We need to bring the muscles together with us in the treatment, no matter the splint that we're using. They're kind of all the same and they're doing the same. However, the muscles need to be part of the treatment. So yes, the tongue is indeed a very important muscle. We need to lift it up. So yes, in the TMJ cases, no matter if they're adolescents or adults, and also the sleep apnea, I'm using the tongue as our ally. So yes, I do use the froggy, and also to answer the question with the expander and what was the other appliance?
The myofunctional therapy itself and the expander.
Well, this, you know, in my point of view now, there is no magic device. So even though it does the right things, it needs to be helped. So yes, I do integrate the myofunctional exercises, no matter the myofunctional device, even with froggy, no matter the appliance that I'm putting in the mouth. I do believe in the exercises that are being repeated in terms of tone.
Even more that for the people that were not there, we previously organized a lecture with a French speech therapist that are a little bit also myofunctional therapist in France, to show you that we are promoting this common use, not only saying we should only use our device. Sometimes it can be efficient, but if you want to get the absolute best results, always add the follow-up, the clinical experience itself.
Course.
There's many questions regarding a lot of documents that you were showing during the lecture and speaking about, and many people are asking you or if they can find some clinical record documents, the ones for the strategy. Are you having some of those documents available online, or is that only stuff that you built on your own?
This is my cases, but I'm more than willing to share the protocols. You just need to contact me and show me the exact case that you're interested in.
Yeah, that's why you were having, or for the ones that do not know what's your email address, at what email address, maybe that we can also contact you on the Instagram or social network.
They can contact me on the Instagram. Indeed, I did not put the email address. So they can contact me on Instagram. It's totally fine. I will answer as soon as possible.
That's perfect. So keep in mind, if you were having some documents that you are thinking, oh, this can be useful for my clinic, you can contact and follow the Instagram accounts of Dr. Ilia Jipa. A question also on the explanations that you were giving. How are you explaining to patients and parents of the patients what's the genesis of the malocclusions that they are treating, and how are you making them aware and understanding about the importance of something like meaningless as the tongue that is having such a big impact? Are you having any tips for that?
Let me understand the correct question. I told in my presentations that before I made a material that I would send to the patients to make them understand. So the question is if there are any tips and tricks regarding what I'm telling to the parents?
Yeah, is there something that you are adding, I don't know, or so you are sending the video itself to the parents and the patients? Are you, for example, watching it live with them or just saying, Open your emails, look at that, and everything will be clear.
So I did construct a lot in these years, and it was kind of difficult until I found my own protocol. So at the beginning, I told you I spoke a lot about the subject, and I would overwhelm them. I'm not sure they would even understand 20% of it. So that's why I made that material where I would explain about the breathing, about the tongue, how they work together, why the tongue is important, because of course nobody cares about the tongue and nobody knows about the tongue and how it could help us. So yes, that material is gold, because they would definitely know what will happen and why I would look at the tongue first and not at their kids' teeth. After that, I definitely show them the pictures, and I ask them to film. It's very important for them to notice these things before, or if they did not do that after we have the first consultation, I make them aware on 4 things: how they chew, where they chew, what happens to the saliva, if they ask water while they're eating, because we don't need any type of aid from water, and the sleeping, the posture when they're watching cartoons or they're doing activities. So yes, I do have to make the parents aware, as much as aware as possible.
You spoke about lots of different acts and exercises that you can add also in this philosophy of always providing exactly what the patient is needing. Many people ask you questions regarding those exercises. So, for example, there is one question, can you please elaborate on frenectomy exercises? Another one on chewing devices that you are using. Can you tell us a little words about all those different exercises that you are giving?
This is why I mentioned AOMT and Samantha Weaver, because they are having, kisses.
I don't know where you're on which camera, but on all of them.
So she does have this program that I also followed, because this is adapted and it's made particular for these exercises. These exercises I am not doing in the practice, even though I did follow the course, because I don't have time for that. That's why I have trained people. As I mentioned, I do have people in my practice that are working side by side with me. These are speech pathologists that are trained to be myofunctional therapists. So these exercises do indeed follow the muscular type of groups. However, if you have a tongue problem, you cannot just do the tongue exercises and make a miracle out of that. The programs for myofunctional exercises start from breathing, going to how to chew, going to how to swallow, to the lips, to the tongue. So they take all the muscles of the face that are being put in a program like that. So if you are interested, AOMT is a perfect place to do the program. The program itself.
You can, so first of all, contact them online and also follow the AAMS, Academy of Applied Myofunctional Sciences, that is also managed by Samantha Weaver, that we are celebrating today if she's listening to us, and that is doing a wonderful job to teach to all the therapists all over the world what are all the different exercises that you can put into action to be more efficient for that. There is one question that is not going to be that easy to accurately answer, but I really love the subject that it is discussing. It's how many times has the hypothesis been confirmed that oral dysfunctions have direct or indirect effects on posture?
100%.
So easier to answer than what I was expecting.
Yeah.
Can you, since when was it that clear for?
Well, first of all, any dysfunction in the muscles lead to a forward head posture. This is a compensatory movement that you don't even see it when it happens. It's something totally natural. So each time, for each centimeter that the head goes forward, this adds a weight to the cervical spine. So normal weight of the head, it's like a bowling ball, like 5 kilograms. For each centimeters that adds, the weight of the head can go up until to 19 kilograms. So imagine wearing a weight like that every day, and I'm not talking about adults, I'm talking about adolescents, like our kids that are walking with all those backpacks in their back and with 19 kilograms in front of them. So yes, the body and the head and the bite and the teeth and the breathing and the tongue are all connected because we are a whole.
It's very important, this aspect, because when I'm speaking to my friends that are not part of the authentic or functional world, they are always probably the most surprised about that, because they couldn't think a single second that something like tongue posture would have such an impact, which is also opening, when we're speaking about the posture, other fields that are very interesting. I think especially, for example, about sport performances, that is now a field that a lot of people are dipping into to be able to assess what's the impact that we can have on the increase on sport performances thanks to myofunctional therapy. So I really love these aspects because it opens a new way that we are still not sure until where is it going. So I really like that aspect.
We are all interconnected, and we are definitely a whole from head to toe. In terms of tongue position, I already mentioned in the presentation, that's why I said about fascia. We don't speak about fascia. We all know what fascia is, and we all been probably to massages and know how to touch the fascia depending how deep the therapist goes in. However, the picture of what I showed in terms of the deep front line, the connection of the tongue to the toe is definitely a real thing. So any lowering of the tongue, I also mentioned the hyoid bone. In terms of the hyoid bone, any restriction in the fascia moves the hyoid behind, and therefore the airways are restricted. Therefore the head will go forward. So the movements are like in a domino effect. Any restriction leads to another compensatory movement. It doesn't matter where, but it happens, and it's natural. It's natural.
That's very interesting, because there is always a debate that I'm hearing on the myofunctional world, which is always asking, wondering, should we first treat the breathing to help to fix the swallowing, or should we treat the swallowing and tongue posture to make easier the rehabilitation of nasal breathing? But the truth, as you said, is that everything is interconnected. So there is no sense in saying we should do that first or then in a second step, while actually everything is influencing each other. And I was really appreciating the work of few myofunctional therapists that could say, I can work on all of them together, because that's how I will get the quickest results, and as quickly I get the automation of the functional balance, better it is for my patients and its development.
Yeah, indeed. I did not believe it neither at the beginning when I've heard it didn't make sense. What the tongue has to do with the breathing? It was not, something I've never heard. And it's not me who I said it. It's the president of the Organization of Health, which had that tongue. The tongue is the respiratory organ.
I think it's Takashi Ono that was saying it first.
And you can do a simple test. You can ask the parents, look, this is a tip and trick that I would definitely like to give. I'm asking the parents to open their mouth and keep the tongue down or stick it outside and breathe through the mouth and feel the air, the volume of the air that enters their lungs. And then I'm asking them to open also the mouth big, and lift the tongue up. I will put like that. To lift the tongue up behind the papilla and suck a bit the tongue to the roof of their mouth and ask them to breathe. Of course, they will not be able to breathe, and then they will say, aha, so this is why we need to put the tongue up. You just need to show them. Also need to make them aware that when their kid is with an open mouth posture, the amount of air that's unfiltered, not treated, not sterilized, is entering directly to their lungs. And when they realize that, they have a different approach. You need to show them. You need to not just tell them. You need to show them pictures. That's why we're using all these types of tools to help us communicate with them better.
I think that you said something very important regarding the tip of the tongue. Mm-hmm. Because some people are sometimes only thinking and focusing on the tip of the tongue. And if you are only focusing on this part, you are then doing that and keeping the back posture of the tongue low and saying, I don't understand, it's not working as it should be, even though I'm putting my tip of the tongue on the right position. What you are saying is very important and should not be forgotten by our audience. You said that you are pushing the tip of the tongue behind the papilla, and then that you are raising all the rest of the tongue
up
to have the back part, and especially the styloglossus, high. And that's what we really have to say to the audience. What is making the tongue posture efficient on the breathing rehabilitation is the fact that there is this high styloglossus that is actually creating a natural seal to avoid mouth breathing. That's the fully natural seal that you are naturally using without needing to think about it when you are a regular nasal breather. I have to say that there is a lot of wonderful comments in the chat. I just read to you a few of them. That is such a fantastic presentation. Thank you so much for RGH certified in myofunctional therapy from Vancouver, Canada. Huge thank you. Or there is this other comment. Congratulations on your presentation. Very well explained and delivered in a calm manner. I love the multidisciplinary approach to treat myofunctional disorders. So we are very glad of all the support that you are bringing to us and to Dr. Ilia Jipa for the presentation. As I was telling you at the beginning of the lecture, I told you that this one will be especially a real good one. Time is flying, so I just have, even though a lot of questions have been asked, feel free to ask them online, on social networks, commenting the video, or sending us email. Few questions had already been answered during the presentation, so you can watch the replay that you're gonna receive in the next days to get all the answers for that. I just keep for the last question, one question that is always coming, and it's always interesting for me to listen at the answer of every speaker. At which point are you saying in general that you should put a froggy mouth in the mouth of the patients? And for how long in general it should be, for example, when you are saying to the parents, for how long will the froggy mouth wearing last?
So now, at this point of my life where I tried all the protocols possible, I am aware that most of the patients do have some muscle dysfunctions. The fact that they don't have space, the fact that they have crooked teeth definitely will need the help of a myofunctional tool. So I'm using Froggy no matter what. It's very easy, it's not so expensive, so it's integrated very well in between the treatments. It's easily accepted even by the disabilities kids. So yes, I do use it a lot in, I don't know, 80% of the cases. How long do I keep it? So I usually keep it active for 6 months, but it depends on the case. It depends what I see. For example, in the case of the kid who had the rapid palatal expander and the fence, and it was not resolved in 2 years with that, and even now we are struggling with Froggy, for sure I will keep it for as long as he needs to see the results that I'm looking for. The low tongue posture during rest and of course during swallowing.
It's a very interesting and important answer that you are giving, because there's first the general timeline that you are considering on your mind and that you are giving to the parents, but then you're also fully aware that what matters is not to stick to the initial plan, and if a patient needs it longer, active or passive way, you do it, because that's at the end of the day what is always leading all the clinical decisions you can make with the froggy mouth, of course, for the device as well, but especially with the froggy mouth. You are managing these treatments, you are the specialist, and so everything that we are showing you during those lectures are only tools to help you to always take the best clinical decisions, but never give up about the importance of following your clinical experience to take the right clinical decision. Thank you so much, Dr. Ilia Jipa, for coming here in Paris, where we are so glad to welcome you at the Biotech Dental Ortho studio for the webinars. It was absolutely wonderful to listen at you today. And if you have a last word for the audience, I leave you the floor.
Reach out anytime. I'm more than willing to talk, to find people that talk like me, think like me. It's amazing because we are not so many. In my country, I'm not the only one. There are others, and which I say hi to them. We really are a group of people that are seeing things differently, and we are not very liked by a lot of others. I used to be focused on forces orthodontist. I would never dream of looking at the tongue first. So reach out, believe in what you're doing. The results, as I saw and as I feel, are completely different than just aligning the teeth. Believe in yourself and keep going. And I'm sorry for my English speaking. I do speak English, however, I am sometimes not finding my words. So if I interrupted a bit, the presentation was completely
Don't worry,
out of
they're
my...
used to listen at me and my father, so you are by far way better than that.
Yeah. So thank you for being with us tonight. Reach out anytime to me, to the Froggy team. They're a fantastic presenters. As I told you, they have that PowerPoint with neuroplasticity that will definitely conquer you from the start. So good luck. Happy holidays, because we are entering a new year, and may all of us be healthy and happy.
Thank you so much.